Today we are going to talk about the symptoms and causes of metabolic acidosis. Furthermore, we will discuss the body's compensation to attempt to correct this problem as well as the standard treatment for metabolic acidosis. Finally, we will talk about a study completed to assess the use of veveramir for patients with metabolic acidosis and chronic kidney disease. Simply put, metabolic acidosis occurs when the body fluids contain too much acid. This can mean either the body is producing too much acid or not properly removing enough acid. This state is characterized by low levels of bicarbonate and high levels of hydrogen, not associated with the carbon dioxide changes of respiratory acidosis. The decrease in bicarbonate without carbon dioxide alteration results in a lowering of pH levels, which is known as acidosis. Severity of metabolic acidosis is determined by the reduction in bicarbonate levels. As depicted in this illustration, a bicarbonate of 22 to 29 milliequivalents per liter is considered normal. A bicarbonate level between 12 and 22 milliequivalents per liter is considered metabolic acidosis. Finally, a bicarbonate level less than 12 milliequivalents per liter is considered severe metabolic acidosis. Many of the symptoms of metabolic acidosis are due to the underlying conditions that cause metabolic acidosis to occur. Also, many of the symptoms are not exclusive to this condition. However, some of the most common symptoms experienced include headache, decreased blood pressure, increased potassium known as hyperkalemia, muscle twitching, flushed and warm skin due to vasodilation, nausea or vomiting, decreased muscle tone, decreased reflexes, confusion, and increased drowsiness. Many diseases, conditions, and substances can cause metabolic acidosis to occur. When metabolic acidosis occurs, the cause can be narrowed down into two categories. These categories are exclusive based on an increased anion gap or a normal anion gap. We will discuss the anion gap in the next slide. Furthermore, mnemonics have been devised in order to aid in remembering the causes in either case. For increased anion gap, metabolic acidosis, the mnemonic is a cat's mud pile. In order, these causes include alcohol ketoacidosis, carbon monoxide and cyanide, aspirin, toluene, starvation ketoacidosis, methanol, metformin, and methemoglobinemia, uremia, diabetic ketoacidosis, paraldehyde, phenoformin, and propylene glycol, isoniazid, and iron, lactic acidosis types A and B, and ethylene glycol. On the other hand, the mnemonic for non-anion gap metabolic acidosis is fused card tip. In order, these causes include Fanconi syndrome, ureterostomy, small bowel fistula, excessive chloride in the form of sodium or ammonium chloride, diarrhea, carbonic anhydrase inhibitors, Addison's disease, renal tubular acidosis, drugs including spironolactone, amiloride, cholestyramine, and triamterene, toluene in a chronic setting secondary to renal tubular acidosis, alostomy and pancreatic fistula, parenteral nutrition, and posthipocapnia. The anion gap, as depicted in this illustration, is the difference between the positively and negatively charged ions. Obviously, many different ions are part of this calculation. The bigger the disparity between the positive and negative ions, the higher the anion gap is. When an elevated anion gap is detected, it is indicative of increased acid and therefore metabolic acidosis. The most obvious reason this difference occurs is because bicarbonate levels decrease, which causes the anion gap to increase. However, as discussed before, it is possible to have metabolic acidosis without an elevated anion gap. As a survival mechanism, the body makes an effort to correct the metabolic acidosis imbalance. On the left of this illustration, the decrease in bicarbonate without any change in carbon dioxide levels results in a pH decrease. To try and compensate, The body performs three main tasks through the respiratory and renal systems, as well as through chemical intervention. First, chemical buffers decrease hydrogen ion by bonding free ions. Next, the respiratory system aids in compensation by exhaling more hydrogen that would be involved in carbon dioxide generation. Finally, the kidneys conserve bicarbonate and excrete hydrogen as well. Together, these three tasks can return the pH acid state back to normal. Of course, if any of these three systems are not functioning properly, acid status would not be able to be corrected by the body alone without medical intervention. Generally, the treatment of metabolic acidosis involves treating the underlying condition. For example, in patients with diabetic ketoacidosis, the cause of the acidosis is high sugar levels from untreated diabetes. In this case, insulin treatment can correct the diabetes complication and therefore aid the body in acid removal and halting acid production. Another method that is beneficial in metabolic acidosis caused by bicarbonate loss is intravenous administration of sodium bicarbonate. This base can serve to replace the low bicarbonate that is causing the metabolic acidosis in instances like kidney problems, diarrhea, and vomiting. In advanced kidney disease causing metabolic acidosis, dialysis may be required to correct acid imbalance. Dialysis involves an external machine filtering blood to operate as an artificial kidney. The illustration provided is an example of a dialysis machine used to filter blood. Finally, if metabolic acidosis is caused by an external substance like drugs or alcohol, it is important to provide supportive care and monitoring during detoxification from this substance. Next, we will discuss a study called Long-Term Safety and Efficacy of Vevaramir in Patients with Metabolic Acidosis and Chronic Kidney Disease, a multi-center, randomized, blinded, placebo-controlled 40-week extension. As a non-absorbed polymer, the mechanism of Vevaramir is shown in this illustration. After ingestion of this suspension in water, hydrogen ion binds to Vevaramir in the gastrointestinal tract. Each bound hydrogen ion in the GI tract causes a bicarbonate ion to enter the bloodstream. Furthermore, Vevaramir also binds to chloride ions in the GI tract that are provided by the exchange of bicarbonate into the blood. Both hydrogen ions and chloride ions are carried by Vevaramir through the GI tract for feces excretion. Ultimately, the introduction of this medication causes excretion of hydrogen and chloride ions and facilitates increased bicarbonate in the blood, which is necessary for metabolic acidosis reversal. As a 40-week extension of the parent study, this study involved a multi-center, blinded, randomized, and placebo-controlled approach. Including 29 sites in 7 countries, the control group consisted of patients that met the inclusion criteria and were given placebo. On the other hand, the experimental group consisted of patients that met inclusion criteria and were given Vevaramir. Inclusion criteria of the parent study included 3 bicarbonate levels, of which the first 2 and the average of 3 had to fall within 12 to 20 millimoles per liter, and 2 glomerular filtration rate measurements that were between 20 to 40 milliliters per minute and were not more than 20% different from one another. Furthermore, extension study inclusion criteria included patients not dependent on dialysis who had completed the original 12-week parent study and had a bicarbonate level of at least 12 millimoles per liter. Finally, patients in both groups were excluded if their bicarbonate levels reached levels low enough to require emergency measures, if they required dialysis for either acute or chronic kidney problems, if they had a plan for kidney replacement or dialysis within the next 6 months, if they had a cancer diagnosis, gastroparesis, bariatric surgery, bowel obstruction, any disorder that made swallowing difficult, disorders or major surgeries of the GI system, inflammatory bowel disease, ulcers, or calcium levels at or below 2 millimoles per liter. The chart provided details those that were randomized and why some patients were not included in the final analysis. The primary endpoint of this study was to evaluate the safety of vevaramyr by evaluating adverse events. As exemplified by the table on the right, vevaramyr was shown to be no different than placebo in regard to the safety profile. Furthermore, the graph on the left shows a statistically significant difference between the number of patients in the placebo group that died, required renal replacement therapy, and or had a 50% or greater decline in glomerular filtration rate. In fact, the vevaramyr group had only 4% of its patients that fell into this category, compared to 12% in the placebo group. This study showed that vevaramyr had a statistically significant advantage compared to placebo in safety and increase in serum bicarbonate. In fact, the vevaramyr depicted by the blue line shows a quick and steady correction of serum bicarbonate compared to placebo. 63% of vevaramyr patients compared to 38% of patients given placebo were recorded as having an adequate and significant response to treatment. At all points starting from week 1 forward, vevaramyr patients had a greater bicarbonate change from baseline than placebo. Furthermore, the mean change for patients at treatment completion was 4.7 millimoles per liter in the vevaramyr group compared to only 2.7 millimoles per liter in the placebo group. Finally, after vevaramyr withdrawal, bicarbonate levels were not different between the two groups, further signifying the effectiveness of vevaramyr therapy. Finally, as depicted in this chart, patients taking vevaramyr, as depicted by the blue line, had an increase in physical functionality that was statistically significant compared to placebo. The top graph represents this data as the KDQOL-PFD score, which measures limitation in daily activity performance. The bottom graph represents the physical functionality increase by the time required to perform chair stands repeatedly. In conclusion, this study not only provided adequate and statistically significant data that vevaramyr is safe, but proved its efficacy in metabolic acidosis correction. Not only did patients greatly benefit from the correction of acidosis itself, but the study also cited the physical functionality improvement of life that this correction provided patients.